really is a real honor for me to be here today at the start of your series. I want to start by introducing you to Mona Devi, and in her arms is her 6-week-old infant. She lives in the state of Bihar, which is in one of India's biggest states, a population of about 100 million. And the fact that I can say to you that she lives means that this is a good story. Because, as many of you know, maternal mortality rates are still really very, very high. In many countries of the world, about 98% of the women who die around the time of childbirth do so in low and middle income countries. So this is one of the examples of the greatest disparities that we still have in health is in the field of maternal and newborn health. So Mona Devi, and I use her name with relish because she's given us permission to tell her story, signifies a real opportunity for change that is happening. And I wanted to tell you a bit about it and use it as an example of what really could be done. So she delivered her full-term healthy infant in a remote health center, and there's quite a debate going on in the world at the moment. Where's the best place to deliver babies? Because bad things can happen unexpectedly if you're delivering a baby, and as it did to her, she had been given the oxytocin that you're supposed to give a mother after birth, but then she developed a bad postpartum hemorrhage. An ambulance was called. They gave her IV fluids, and in fact, she developed cardiac arrest on the way to hospital, and the ambulance crew resuscitated her with cardiac compression en route. The district hospital ahead had been alerted using a WhatsApp referral system. And when she arrived at the hospital, the blood was already ready for her. She had B positive blood, which was secured ahead of her arrival, and it was delivered promptly to her as she arrived. And her life was saved. So that's a kind of an amazing story in a country that has really struggled to deliver good care, safe and reliable care to mothers. Let's look at that same district hospital 18 months previously. Now, I can't show you the picture of PD, the mother of 3. She developed postpartum hemorrhage at birth at that hospital due to a cervical tear. She'd been brought in great abdominal pain, delivered almost immediately, and tore her cervix. There was an urgent requisition that went out for blood. Now, this was declined because of a rule that they had that you can't release blood from the blood bank unless a family member donates blood to replenish the supply. So there was a lot of negotiation, and eventually the blood was released after repeated requests. She was sent to the ward, and when the blood arrived, she wasn't given the blood because of poor communications within the hospital. So nobody really knew who the blood was for. She was back there in the postnatal area, and 4 hours later she was found to be pulseless and in shock. She was put in an ambulance to go to a referral center, and after 20 kilometers, the ambulance returned with her dead body. So this is kind of probably the more normal situation that we're encountering, and that we're trying to help think through what would be involved to try to turn this around to get to the situation with Mona Devi that I told you about previously. So what did they do over the 18-month period between that horrible story and the one that I started off with? Well, they took a systems approach. First of all, they realized that they needed a quick response team for this kind of situation because you can't predict when a mother who's giving birth is going to run into trouble. One of the most amazing things is this WhatsApp communication system. So mHealth has been used quite extensively, but the results are kind of very unconvincing for a lot of mHealth unless it's used and integrated into a system like this. So they had an advanced communication system that they used that alerted ahead. All they do is they take a photograph of the mother's transfer sheet, WhatsApp it ahead to the hospital, say this woman is coming. It does a few things. Obviously, it lets people, let them know what's coming ahead. But it deals with one of the most awful things that happens, which is often that ambulances get diverted to the private sector, who are no better equipped to deal, in fact, in many cases, worse equipped to deal with this kind of emergency. So that the mother has a much better chance of making it through to the hospital. And of course, the blood would be available. And one of the things that the team did was to negotiate that in an emergency, this rule of replacing blood doesn't apply. A lot of work, clinical work done on improving the resuscitation skills, and also a lot of quality improvement to make sure that those skills are used every time there's an emergency. So it's all very well having the skills, but you need to have systems in place that are measured that tell you that this is actually being done. And then finally, working with the ambulance service to improve the response times. So you see this is a complex system which requires many actors, and it requires bringing them together. And this is what the method does, is it brings these many actors together to solve problems that all of these solutions came from people at the front line. These were not policy changes. The policy changes followed the suggestions that were made by the people on the ground. Data is an absolutely intrinsic part of this. So you can see the three processes that were measured: the percentage of women who were actually reached, who were sent from primary health care, who actually reached the district hospital. This is an incredibly important measure of success, and you can see how this increased over the time of this collaborative. The second one is, and I have to look here, it's the percentage of PHC referrals where WhatsApp was used to communicate ahead for a pregnancy communication. And very importantly, did they succeed in getting the blood transfusions for the woman who needed it? You notice that this is not a before and after study. This is continuous data that is made available to the teams who are trying to solve the problem, so that they know now that their solutions are actually working. So, and you can see it's annotated with the ideas that were used to try, because not every idea is going to work. You have to keep looking back and making sure that those ideas are working. This use of WhatsApp is extraordinary. This is the actual WhatsApp that is shared. So it's not only just communicating in times of emergency. There is a social network of communication that happens celebrating this kind of success. So this is somebody describing what happened and celebrating it so that everybody else is aware about what is possible. So this is getting at what I'm going to talk about, which is what are the conditions that are required and what are the methods that are used to affect this kind of impact. I'm going to talk a little bit about making sure that this doesn't get stuck in some kind of a pilot, about how do you scale something up like this. And then finally, it's all very well for us as IHI to go and advise and train people in this methodology, but what's going to happen when we leave? What is the latest thinking really about sustainability? So those are the three things that I want to talk about. This comes at an exciting time. As many of you may be aware, there were 3 reports last year that commented on the state of global health quality. If you haven't read them, I would strongly recommend that you do. They are really rich descriptions of both the current state and some really good ideas about what to do about the quality gaps in low and middle income countries. One of the striking findings from the Lancet Commission, which I had great privilege to be part of, was that people are dying as much, or if not more, from poor quality than from just simply access. So there's been a tremendous access through the universal health coverage movement to get people to come to the facilities. But what if you come to a facility and there's terrible care? So this piece of data is extremely important. Of the 8.5 million people who could be saved every year due to quality issues, 3.5 were due to access problems, and 5 million people died because when they were at a facility, they didn't get the proper care. So it's a stunning realization about the importance of improving the quality that people receive when they actually make it. One of the bits of data that actually has driven people to understand the importance of quality once you actually get there is the data from India on maternal mortality. And there was, many of you may be aware of the financial incentive program, conditional payments that were given to mothers if they actually turned up and had their babies at a facility rather than having them at home. So they succeeded in getting a huge number of women to turn up at the facilities. It went from about 30% to about 70%. But look at this graph here that shows the relationship between deaths and institutional delivery. There is no relationship, okay? And that's because the quality of care in the facilities actually turns out to be no better than what they were getting at home. So this is both a wake-up call, but it's also an extraordinary opportunity about how lives could be saved if you could improve the quality of care at the facilities. The other important piece of data, which is kind of intuitive, is that the poorer you are, the worse the quality of the care that you receive. So these are quintiles, economic quintiles in upper middle income countries, low middle income countries, and low income countries. And you can see that there's a difference in if you're in one of those countries, but within those countries, there's a huge difference in your survival depending on what economic band you're sitting in. It's not just not enough quality and not enough care, and it's also too much and overuse of medicine. And the one area that we're very involved with is cesarean section. And cesarean section is the example of, in some countries like in India, as I'm going to show you, we're desperately trying to raise the percentage of numbers of women who get cesarean section. And in Brazil, where we're working in hospitals that have never, obstetric hospitals that have never delivered a baby naturally. 100% of their babies are delivered by cesarean section. That's a middle-income country. And if you look at this graph here from this wonderful article in the Lancet, which is titled Too Much, Too Soon, Too Little, Too Late is cut off. The countries in blue on the bottom left of that graph are low-income countries. The countries in red on the right-hand side are middle-income countries. Those countries have all got cesarean section rates above 40%. WHO says you shouldn't do, there's no population benefit to doing cesarean sections if your rate goes above 15%. The high-income countries are in green, and you can see that they're all hovering between 15% and 30%. US, 34%. Okay? So this is a problem. Quality is not just too little medicine. It's too much medicine inappropriately. And it's interesting that the highest rates of cesarean sections are not in high-income countries, they're in middle-income countries, for all sorts of reasons that we don't have time to go into. So what's the problem we're trying to solve? And many of you have heard about the know-do gap. So on the top line there is what we know, and the bottom line is what we're doing. The interesting thing is that in 2001, there was a study by Beth McGlynn that many of you may be familiar with about the quality of pediatric care in the United States. And what she reported was that your chances of getting the right care, if you walked into a doctor's office, if you had a child walking into a doctor's office, was about 50%, that you would get exactly the right care for that right child. The Lancet Commission just reported that same number, 50%. Your chances of getting care pretty much around the world is around 50%. So what can we do to close that gap? There's more and more knowledge coming out. And how are we going to close the gap between what we should be doing and what we're actually doing? And that's what I want to talk about, the three areas that we'll talk briefly about. One is, how do you get impact? Secondly, how do you scale up something that works? And then thirdly, how do you make sure that it sticks around sustainability? So there's lots of advice about what to do. This is the Lancet Commission framework for action. It's got the 4 universal actions: improve governance, redesign service delivery, in other words, let primary care take care of primary care type problems, transform the health workforce, get them better pre-service training, and particularly the 4th one, ignite demand, get a much more involvement of the population in the problem. We were pretty proud in my work group to get that learning and improvement in the middle there, because to me, this is really the key. Okay, what can we learn and how do we use that learning and build that learning into a systematic, rigorous improvement process. So let's start off by thinking about impact. What works? Okay, there's a lot of discussion about what works, and I think I'm going to cut to the answer. What works is that a lot of things work. But you have to make some decisions about how you put those things together. This is an extraordinary study, which if you haven't read it, I would recommend. It's by Alex Rowe, who works at the CDC. He actually works in malaria, and was working in the malaria unit, and now he's really dedicating his time. He sifted in his team, mostly with his wife, through over 200,000 citations, looking at what strategies influence the performance of health workers. I want you to just stop for a second, and if you were to pick out the top 3 out of this list, just think about it for a second. If you said, what is the most effective way of improving provider performance, just have a look at that list for 30 seconds on your own and see if you can come to a conclusion about what would you pick if you were a system leader and you had to pick 3 interventions. Somebody want to volunteer what their top 3 would be?
Yes. Community support, strengthening infrastructure, and training.
Okay, community support, strengthening infrastructure, and training. Okay, thank you for volunteering. Because you've kind of, community has come in more recently, but infrastructure and training are the 2 things that rarely have been used. Those have been the sort of the mainstays. If you put the inputs in place, and if you train people, they should be able to do the work. So what he found was this, according to the studies that met the criteria for his study, the number 1 single intervention that actually changed the way that health providers performed was group problem solving using methods that are similar to the quality improvement collaboratives. The second single intervention was other similar management techniques that included things like self-assessment and group process, then supportive supervision, and then any training, then printed information, health system financing, you can see on its own. So these are single interventions. Community, which is what you'd mentioned, and infrastructure and provider incentives, etc., on their own they weren't sufficient to make it to this list. So we don't know, but we know from the World Bank that performance-based financing has about a less than 10% impact on improving. So very low impact when used on its own. Look what happens when you start to combine these. Okay, so if you put infrastructure plus health financing plus supervision, etc., you get a pretty big bang. But group problem solving, like QI, plus any training, gives you almost the same impact. Or I can guarantee you a whole lot less money. And can you imagine if you put those 2 things together, what your impact would be? So if you look at the single interventions compared to the combined interventions, you get obviously much less. But if you're going to choose a single intervention, what I'm trying to advocate for here is the power of learning and improvement, systematic improvement methodologies added into the mix. So our method is really what we call theory-based change. You start off with a very clear goal of and some kind of identified. I'm sorry, I'm pointing at the wrong thing. I'm pointing at my own screen. So we start off with some clearly identified problem that needs urgent action. If you're not going to work on something that really matters to people, you can forget it. You're not going to get people involved in this kind of methodology if it isn't something of importance to them, not just to you. Secondly, we acknowledge that the route to solving a problem like getting every mother to get a corticosteroid, every mother who's in pre-term labor to get corticosteroids, is reliable implementation of evidence-based clinical processes. So we've got to find a way to make clinical processes evidence. We know this is the what to do. And the how to do it is to get this right. So these are the conditions that have to be present in order for you to get reliable implementation implementation of evidence. Workers have to know what they're doing. They have to have immediate access to the essential commodities. They have to have a simple, common view of how the system works. They can't be faced with a 200-page protocol. They need a simple pathway: screen, classify, and treat. That's a simple pathway that everyone can get behind. The motivation for change has to come from leadership, and you tap into the intrinsic motivation, which is not money, I can tell you. It's because people who are in the situation want to be enabled to do the right thing. And they have to be supported with data systems in real time, and then a system that can learn from all of this and incorporate it into better designs. That's the basic theory of change for an improvement system. And I'm not going to go into this, but this is basically what sits behind it. These are all the ideas that will drive those basic elements to change the system. And these ideas, typically, how to do this has to come from the front line. Okay, we can learn how it was done in the next state or the next district, sure. We can bring that in as our baseline, but context is so important that the people at the front line have to be given a systematic way of bringing their own ideas into this set of systems that support the drivers that can drive reliable implementation. It's a complex system made simple, okay? So that the person at the front line can actually use this in their everyday work. The typical way in which implementation is undertaken is that there's a problem that's identified. Somebody sitting in some office comes up with a solution, usually laminates it, sends it to the front line for implementation, and of course it's going to hit some unforeseen system barrier and it's going to fail. That is the standard way of trying to solve a problem. The new way of trying to solve a problem is to send the problem straight to the front line, because the people who are doing this every day almost certainly have a good idea about how to do this. You teach them, this is a fishbone, which many of you may be familiar with, you teach them how to analyze their own systems, come up with good ideas for change, or ideas for change, and not all of them are going to be good ideas, because then you have to do a rapid cycle test. Many of you may be familiar with the plan, do, study, act cycle, okay? And this has been corrupted, okay? So it's been taken by management. Yes, we plan, then we get them to do it, then we send a team in to go and inspect it, and then we act, which is usually to punish somebody or to praise them. That is the slow, what we call the slow and fairly destructive plan, do, study, act cycle. The PDSA cycle we're talking about is taking ideas, and the people who are responsible for testing them are the people working on the front line themselves. There's a much greater chance of being implemented because they own it, and it has a much greater chance of succeeding. That is the essential of the frontline method. Okay. So what else? So this whole way of looking at improvement came from Edward Deming. Many of you may have heard of Deming, but Deming basically changed mostly the automobile industry. He was spurned by General Motors and Ford, much to their regret, I think. And so he found a home in Toyota. Okay, and I think it took the U.S. automobile industry about 20 years to catch up to what had happened, because they didn't take the advice from Deming. And he said there are 4 things that you need to change a system for the better. First of all, this rapid, continuous learning, using ideas from the front line. The second is an enabling environment. I took this photograph last week in Bangladesh. Okay, this is the, right out of the picture here, this is the head of maternal child health for the country. This is the superintendent of the hospital, and this is the head nurse. This wouldn't have happened, okay, even 12 months ago. This head nurse has absolutely no problem about advocating, describing what she's doing, saying what she needs. This is a real turnaround, okay, and that comes from being empowered through understanding that she actually has the power to change what she's doing at the front line through this rapid continuous learning process. So an enabling environment. The story is not over, because she met some significant pushback. Okay, why didn't you do this? Why are women still dying? And our project in India, we spent the first 2 years before we initiated the second phase of the program, just surfacing bad data, just surfacing complications, just surfacing deaths, just admitting that this is happening. Because you can't improve a system that's perfect. And when I went to India 4 years ago, at the very, very start of this, it was a miracle. There were no maternal deaths. There were no neonatal deaths. Because unless that is surfaced, and just, I can tell you, just doing that is incredibly hard work. The third is systems thinking. Often the response is something's wrong, bang, go and fix it. It's highly reactive, and it's never fixing, never thinking comprehensively about the interactions between the different levels of care or the patient journey. That these are all interconnected and need to be dealt with as a whole. And finally, as I said, the use of continuous data. So this is the continuous data by month this is percentage of delivery cases picked up from home by ambulance. The district was using a ranking system. Okay, so when they started, they were ranked 37th. And look, they made all of this improvement. In March of 2019, they were ranked first. But look what happened. They continued to make significant improvement, and then by July 19th, they were now ranked 10th. It's completely meaningless. Okay, this kind of ranking is only for judgment. Okay, it's not for improvement. And so part of our big journey here with the district and with the state is to get them to convert them to this kind of way of looking at data. I'm going to skip over this in the interest of time. I wanted to make some comment about the plausibility of the method. So quality improvement has sort of come under a lot of scrutiny because it's not randomized controlled trials. Okay, and this comes from the sort of the bias of the science community that says you have to use these types of methods that were actually designed for efficacy, not effectiveness. So we're looking at effectiveness here. And we have 2 or 3 main ways of looking at effectiveness. The first is intra-group comparison. So we're looking here at a baseline. We come in with an intervention, and we see a change. Okay? And we're using, this is statistical process control that tells you, this system is stable, it's working within the control limits. And now you can see the system becomes unstable because it jumped out of the control limits. We can use a certain criteria for telling us that there has been a significant change, a very high probability of a significant change, and we are now operating at a new level. And this may well bounce out if you have enough points above the line to a new level of performance as new ideas are introduced. So that's the first way. We have to be careful. There are all sorts of biases that can creep in here because this could be just better reporting. So once the project started, people could just start reporting better. But we have to be very careful about that. The second method is counterfactuals. Increasingly, we're just trying to get access to the surrounding data. This is not perfect because there's selection bias. We're selecting the facilities that are most likely to improve, because that's how we want to start an improvement project. We wouldn't take the worst leadership because we know that we're going to make no progress. But if you look, this is helpful. This was in Bihar showing rates of cesarean sections. No, it wasn't. What is this? Maternal complications. Oh, this is the illustration. We were just trying to surface maternal complications here. So maternal complications apparently went up in the facilities that we were looking at, but that was just because they were being reported. That was a success to us. Whereas you can see the rates of complications were not changed in the counterfactual. So using counterfactuals is another really important thing. I want to switch briefly to the issue of scalability. So many of you are involved in the medical sciences. Okay, so this is a heat map of the health system. I want somebody to volunteer what the affliction is. What are the spots in this health system? What is going on with this health system that it has these hotspots. What are these hotspots? And what is the condition that this health system is afflicted with? Somebody must have an idea.
Infection.
Sorry?
Infection.
The system is infected. It could be a breakout. Yeah, these could be breakouts of a particular condition, absolutely. But if you were to apply that thinking to a health systems problem or a health systems activity, something that many of you may be involved in, what do you do when you go out to some district in Tanzania? What do you set up? You set up a pilot. So this health system has pilotitis. Okay. So what happens with pilotitis is that you have inspired improvement projects, hotspots that deliver great results. Okay? Mostly those hotspots will disappear after the project ends, and particularly if it's been published. Okay? And one of the problems with pilots is that they can't be integrated or scaled up. They're very difficult if you don't design a pilot with scale up in mind to scale it up. Okay. So if you think about the pilot at the bottom here that has achieved your results, and your pilot is you've done this in about 5 to 10 units, and the number of units that you need to get up across the whole district or across the country is about 600. What are your options for scaling it up? So this is the typical one. You'll take your pilot to the government or to the district manager and you show them this fantastic work, and they'll say, fine, let's roll it out. And rollout means everybody gets, starting next Monday or next month, everybody gets the training and the materials, and they scale it up. And what it turns out is what we call empty scale up, because you can go and measure and the fidelity is completely gone. It's a very, very unrewarding and unlikely to succeed way of scaling up. Then there's the forever linear scale up, incremental scale up, which is this next month we're going to do 10% better or 10% better. And there's a lot of that kind of thinking in health systems. And what we propose is what we call 5 times scale up thinking, which is really just, and it can be 4 times or 10 times, but basically here we have 25 units that have achieved, that you have demonstrated a model in. We suggest that your next step is to go to 125 and then to 625. This is politically very difficult to convince people that you're going to have to, instead of doing a linear change from 0 to 625, doing a third, that you're actually going to have to spend this time intensively working on the pilot. You're going to then have to intensively work on the next phase of the project, which is to look at the adaptability or the implementation of that pilot in new contexts. And then finally to go to a very rapid phase of scale-up when you have the confidence to do that. And so this is the scale-up framework which we've published, which has essentially 4 components. It starts with a phased approach. So that's the first component, is to think about this in a phased way that I've just described. A lot of attention to the setup, what you're scaling up, what is known already, which are the first units to get set up in. And this very important concept of the scalable unit. What is the unit that you're going to replicate? It could be, if you're in a hospital, it could be a ward. If you're in a district, it could be sub-districts. If it's a sub-district, it could be all the facilities. So they are the units that you want to replicate. And you have to get it right. So you spend a lot of time working on the scalable unit, as I showed you in that example. Then you have to test in different contexts. It could be urban, rural, poor, wealthy, hard to get to, etc., to make sure that this that has worked so well for you in your very intensive phase can work. And then when you're really confident, you can move very fast in taking this to full scale. The second component is will. This has to be an attraction. If the scale-ups often fail because people feel like you're pushing stuff on them. If you make your change so attractive and so exciting and you publicize it so well, people will want to know about it, and they will want to know why you're not choosing them next. The third is you've got to be pretty confident about the ideas that are different from the ideas right now. This is building new standard work that you insert into the system. And then fourthly, the infrastructure. You can't just scale up unless people know how to do it, unless they're trained to do it, and particularly that they have the support to do it. We spend a lot of time on developing tools, data systems that work, that can support this work. So these four elements have to be in place. This is an hour-long talk all of its own, but what I wanted to show you here is that this has actually been applied at a national level now for quite a few countries. So this was one of the first that we did in Ghana, and we were helping the government of Ghana to try to achieve its MDG 5 and 4 goals around under 5 mortality and maternal mortality. And as you can see, it follows the basic pattern that I just described, a startup phase where we got to know the country, got to know what was there, building off what is already there. The second is trying it out on a very small scale in the first 22 months of the project in a remote regions, 3 regions in northern Ghana, learning, will it work if we try to scale this in the northern region? Understanding that the southern region is very different from the northern region, so we have to do more testing in the south, and then finally going to full scale. You can see this very methodical, stepwise approach to scale up, including the other 3 underlying elements, making sure the will is there, that the ideas are working, and that you've got the systems infrastructure to support the rapid change. These are the results that came from that project. This is under 5 mortality in the final push in the south, all 134 hospitals in 7 regions. And you can see a pretty stable baseline of under 5 mortality in the hospitals. This is the case fatality rate per 1,000 admissions, coming down very significantly during the time or after the time that the project was initiated. Again, this is tough data because we don't have a counterfactual. What we have is the rate of change before, and we have a significant association as the initiative ramped up, and then we had to pay very close attention to what else. So when we published this, we had to give a full account of everything else that was happening in the environment to make sure that we weren't attributing to ourselves something that some other big initiative had been responsible for. You wanted to ask a question? No. And then I'm finally going to talk, because I do want to finish at 1:45, so we've got some time for questions. I just want to briefly mention this issue of sustainability. And I'm mentioning it because we at IHI have learnt kind of the hard way, I suppose, about what sustainability doesn't mean. Okay, and we've seen instances of quite significant sums of money, usually from our association with the Gates Foundation, being put into countries demonstrating a fantastic model, showing a decrease in maternal mortality, and then just running into tremendous problems in trying to hand it off and see it scaled up within those countries. So if it's not designed from the beginning with the government, you can, I don't know about forget it, but it's very, very difficult to transition to true sustainability. This is one of the most depressing examples. In February 2014, and this was the antenatal corticosteroid story, which there's another story about this, which is that a paper came out 9 months after we started this that showed that it was dangerous to use antenatal corticosteroids in low-income settings. But we were on our way. As you can see, this is the head of the obstetric unit at a district hospital, proudly showing off his screening graph, which was outside the labor ward, for how well they were screening mothers for gestation, which is the first step of telling whether a mother is having a preterm labor or a full-term labor. And he is in command, and he is leading this project, and this is one of the most important criteria for success. Okay, a leader who owns it, who is prepared to speak about it proudly, and he's got his team around him, and everyone is really happy. It survived a transition, so he left, and this lady came in June 2014. She had taken over a few months earlier. You can see a few bumps in the road. That's Hawthorne effect. Everyone's really excited. Then it goes back to where it should be, and then this is systems change. and then a few bumps in the road. I visited again in December of that year, and this is what I found. That the sheet had not been completed anymore, and even more depressingly, it had fallen down within the cabinet, and nobody was looking at it. Okay, there were a number of reasons for this. One is this project was so successful that it caused a national stock out of corticosteroids. They were not prepared to use this rate of corticosteroids in the country, and it took about 6 months to get more supplies flown in. And in fact, by the time the more supplies were flown in, the big article came out about saying corticosteroids were dangerous, and so it was never picked up. But even if it hadn't been, that article hadn't come out, this is pretty much what you will see with a quality improvement project that is not integrated into the district, into the state system, right from the very beginning. So this is your pilot that we can demonstrate, and we did, and it was applauded around the world as a great little study, of demonstration study, and then it crashed and burned. Okay, so let's just summarize what is going on here. So we're strongly recommending that we build that in the past, pilots were built from scratch in isolation of the broader health system, a little bit like this. And we're strongly recommending that you build your models off existing experience, knowledge, and structures. We hear this often, the notion of handoff. We'll create something beautiful, and it's very often, we see this in the innovation community, which we're part of, is that we do some fantastic innovation that we're going to hand off to you. It doesn't work like that. That innovation has to be owned from the very get-go. It has to be co-designed and co-implemented with the health system leaders that you're trying to hand off to. And scalability is assumed. If it's such a brilliant idea, of course you're going to take it. Or it's a secondary consideration. Now we've done it, now we can start thinking about scale-up. And so we're strongly recommending that innovation, that we design innovation with scalability in mind. It's all very well to show it in 2 districts or 3 districts, but how are you going to get it to the rest of the country? And then the training, and this is USAID is really so responsible for having measured success, and they've previously called sustainability about your ability to train X number of people. You can train it, or any of you who've worked in these areas know that those people that you've trained are going to last about 5 or 6 weeks until they're transferred to another unit, and that is going to be lost because there's no replication, there's no replenishment system. So unless you build a deep replenishment system into the country, you can forget it. It is just not going to survive. And then finally, we've got to be really careful about disrupting a vulnerable system by, like the HIV was a very good example, sucking a lot of resources at the expense of other systems. So we have to nest it into the broader system. So those are the examples. I want to just very briefly show you. We fortunately, through the Gates Foundation, we were given an extraordinary opportunity to design something like this from scratch with the Ethiopian government. So we spent a year doing a planning study. Okay, even before we went in, the next action was co-designing and co-developing a national quality strategy and the management system across the country to be able to look after quality, manage it, measure it, implement it, and then work with the government on how they were going to scale it up. Right now in Ethiopia, the Ethiopian health system is scaling up its own improvement on maternal newborn based on everything that I've spoken about today. Second is capability building. So we did go and help them build capability for doing systems improvement, which nobody's taught at medical school or nursing school, or increasingly now it's being taught in public health schools, but it just hasn't been taught. People don't know what systems thinking is and this kind of methodology. So you have to basically train that up within the health system. But more importantly, the quality services, the Health Service Quality Directorate was formed, a brand new directorate that reports directly to the minister that has taken on responsibility. All of the IP has been transferred. They're running these courses now in Amaranth, and they are able, I know for sure they're going to be able to replenish the system into the future. And thirdly, you can't just hand this stuff over. You can't just train people how to use it. You can't just build these structures. We really believe in this concept of accompaniment. So both helping to demonstrate, build the will, this is an example of a district in Ethiopia where the compliance for bundle adherence for labor, at the end of labor, end stage of labor, has gone up to 90%. Okay, we know that these 4 things that have to happen around the time of birth are happening across this district at a 90% reliability. That's the level of reliability where you will start to see changes in mortality. And then we will be in the background as they scale up, giving them guidance and advice as they scale up across the country. So that's the 3 critical factors that we believe are, first of all, the impact that the method gives. Secondly, scalability is just huge. You can't be satisfied with your pilots. And then thirdly, truly understanding what sustainability means. So that's all I have to say. And happy to use the last 10 minutes for any questions if there are any.
Yeah, I wonder if you could speak a little more about human resources for health. And, you know, I really liked your points about intrinsic motivation and ownership. And yet at the same time, we know that there's a shortage of healthcare workers often, and asking to add to tasks and asking to participate in additional processes can be really burdensome. What are your thoughts about that? And then and potential solutions. And then also, I'm really curious about your thoughts about task shifting in general.
So on the first one, I mean, you can't do this work without people, and you can't do it without resources and equipment and buildings. So, you know, Donna Median had this inputs, processes, outcomes, as a sort of path to quality. And it starts with inputs. You're 100% right. You could have the fanciest improvement system in the world, and it just simply won't work if you don't have the people, and you don't have the drugs, and you don't have the structures. So I think, the first thing that you can show is that you can get a lot more efficiency with the same people by using this kind of a system. So the equation about what you need may change, which is not to diminish the huge importance of the fact that most of these places actually don't have what they need to just do the basic work. But in my recent trip to Bangladesh, I saw the worst overcrowding I have ever seen in my life at the district hospital. Just horrendous. Newborn babies lying on the floor with their moms and that sort of thing. And then we moved to the next level down, and it was like nobody was there. Okay, and then we moved to the next level down there, and there was definitely nobody there. So when I think about task shifting, I also think about redistribution of the load by building confidence in the lower levels, as well as shifting the actual tasks, because I think that a lot could be solved by redistributing the load within these systems. There's a lot been written about bypassing, women who just bypass the facilities, and we are trying very hard now to build up the attractiveness of the intermediate level healthcare facilities to see if we can impact these bypassing activities, and that remains to be seen. So task shifting absolutely is an important, really important strategy in this kind of a situation, but I have also seen task shifting as a kind of a dumping ground for let's just dump these tasks on the next level down, and then they'll dump them on the next level down, and still somebody finally has to pick it up. Yeah.
Thanks for a brilliant presentation and for your inspirational work. You mentioned that there are some districts that you wouldn't necessarily work with because they're not ready. I'm not sure you used that word. The SDGs, including SDG 3, obviously have this mantra of leaving no one behind, but don't you risk worsening inequity if you leave those districts behind? train? Or how do you promote readiness? How can a district become ready?
I think it rests on this philosophy about scale up that I spoke about here, which is, and I'm sure you're all sort of familiar with the Rogers curve of adoption. It's just a strategy really about where you start and how effectively you can learn. So you're going to learn the most initially from those who really want to change. It's a kind of a efficiency of how you deploy your limited energy and resources. And so you'll learn a tremendous amount from the early adopters. They will bring along their friends, the early majority. Those will, then the late majority are the ones who they're just following trends. Okay, if everyone else is doing it, I'm going to do it. And then you just stay right away from that last group that's just going to try and get in your way. And I think often we have to really spend a lot of time with governments saying, please don't send us to the absolute worst areas, because that's what they want us to do. Is just please go to those terrible areas and help us solve, because we could just get stuck in the mud there. And so we've had to do a lot of work in convincing governments that there is a strategy, and that you have to just believe that you can move very fast. And we know it's been very helpful having the examples of prevention of mother-to-child transmission in South Africa and the under-5 mortality story in Ghana to really show that things can catch fire. Once you've reached a tipping point, you've created a buzz. People really want to be part of this, whatever this is changing. You've got some ideas that you really know work, and you've basically built the support systems to make it easy for them, especially around data. That's how you get the difficult, hard people. But we're 100% with you on the equity issue, and the purpose of this really is to get to the deepest areas. I mean, we've had a really difficult time in South Africa now where they are pushing us to the high-burden TB sites, okay? Which is great as a strategy to show off that you've put a lot of people on treatment. But the more you do that, the more you leave the people in the very deep rural areas behind who are left behind already. So we're very conscious of that.
I'm curious about your thoughts on the difference between academic partnerships and how to avoid pilotitis from I'm a practicing neonatologist and stuff, and so doing trials abroad versus working through an organization like IHI or Gates that kind of has implementation manpower and kind of the reputation for that. If there's different strategies, or if you've noticed a lack of success on the academic side.
Well, we look to you for implementation manpower, because we're a very lean organization. So we work in 40 countries, where we have a total of 200 staff, and we absolutely rely on partnerships everywhere we go. I think that there are some huge questions around implementation methodologies that are not solved. This whole scale-up strategy, we've seen it work in a couple of places. We're really battling. How do you sort of bring governments on board with this? I haven't even spoken about the prevailing quality method is actually an inspection-based system that is incredibly demotivating. Quality assurance says, here are the standards, here are the things we're going to come and measure, and then the inspectors sweep in and give you a star rating, as opposed to the ownership that comes from yourself. I think the systematic study of that process about what really works around motivation, what really works about, the work that Alex Rowe did, this is all post-hoc, but this hasn't been tested prospectively, about what combination of interventions is going to be the best, and then is this the best approach? This exponential scale-up method. We've proposed the framework based on what we've observed. Nobody has tested it prospectively to see actually if there isn't a better way of doing it. I think there's lots of big implementation questions that could be built into design. There's no shortage of opportunity, and so certainly opportunity.
It's a great conversation. I think we're probably going to have to leave it here. Let's all thank Pierre again for